So good afternoon. So we're going to have three topics, brief presentations by eminent people. I think the first one is ECG valuable in diabetes, why and how. And whenever we talk about the ECG and diabetes, we are always focused on the coronary artery disease. So quite often we are able to recollect innumerable anecdotal accounts wherein the ECG has been apparently normal, the patient has had an event. That is very much known to all of us. But what about the conduction disturbances? What about the dysrhythmias? What about the drug effects? What about pericarditis? What about myocarditis? And what about the commonly encountered hyperkalemia? To give few examples, I'm sure. So this is going to be a very, very interesting topic. So as I was reading through this, these are some of the things that just struck my mind. So to do this, request Dr. Arul Raj, can we have his introductory slide on the value of ECG in diabetes, why and how. I talked about the conduction disturbance. I think there's a delay in the organization of the audio-visual so that the type 1 block is already, Yes, Dr. Arul Raj.
Thank you, sir. Good afternoon to all of you. I must thank our chairperson, Professor Venkatraman, for having summarized my topic, where all it should be going to be used. You can all relax a bit. It's all studies. I am going to discuss to you about the role of ECG in diabetes. All of us know coronary artery disease is there when there is diabetes or no diabetes. We always choose for it. But there are certain specific areas I thought I will be able to touch on that. We all know what is diabetes. We all know it is highly prevalent coronary artery disease, and the mortality is also very high, nearly double the number of normal people. And the ECG, it is an electrical recording of the cardiac activity on a paper by Einthoven, which has now progressed from single lead to 3 lead, 4 lead, 12 leads. Now again coming back to single lead. In artificial intelligence with a single lead, we will be able to do that. I'll briefly go through all. And see, these are basically the 7 changes that ECG will be able to detect in diabetic people. One is a subtle alterations, a QT interval or QTC interval, and some fibrotic changes in the base of the heart, and a reactive hypertrophy and a left ventricular, usually coronary artery disease, and then the pericardial fat that could be accumulated, and then cardiomyopathy and heart failure, and all these things. ECG is of value, which all of us know that. The abnormalities to be summarized are in the rhythm. Can be a sinus tachycardia or atrial flutter or a fibrillation. Can be a bradycardia too. Potassium repolarizing current abnormalities, as our chairperson said, hyperkalemia can always be detected. And conduction defect, chamber hypertrophies, and baroreceptor dysfunction due to cardiac autonomic neuropathy. These are the factors that stimulate the occurrence of ECG changes in diabetes, age, sex, smoking, alcohol, stress, all those things. We'll go into some of the clinical examples. In a normal person with diabetes, asymptomatic, take an ECG, there can be a change, which many of us have seen that. See this ECG, we are able to see a DPS in lead 3 and an R in lead 1, which indicates a left hemiblock. And this is a patient is totally asymptomatic. And there can be a resting persistent tachycardia compared to a normal person. In diabetic person, it is very common, especially related to high blood glucose level and insulin level, which is very common due to insulin resistance. This is not abnormal, need not be treated, difficult to treat, don't put on calcium channel or beta blockers. And bradycardia, again, very, very common in senior citizens due to cardiac autonomic neuropathy. When is simple sinus bradycardia, only observation is needed, which we will be able to detect it. And a chronic heart block is very common. They may not have a clinical evidence of a coronary artery disease, but due to an atherosclerotic heart disease, there can be a heart block, which can be due to a microangiopathy or a metabolic abnormalities, ischemic heart disease, and autonomic neuropathy. And cardiac autonomic neuropathy is causing neuronal ischemia and cellular death, and that causes neurological abnormalities, especially in QT interval and QTC. They are prolonged. They are the forerunners for ventricular tachyarrhythmias. Therefore, we will have to be very careful with them. Here is a QTC. You don't have a pointer here. I mean, you are able to see a QTC, prolonged here, which as clinicians we should watch. These people may end up in either complete heart block or a ventricular tachyarrhythmias. And diabetic cardiomyopathy, which has come out as a specific entity today, it causes, which one? Right, this green. Okay, it can cause a left ventricular hypertrophy without hypertension or an aortic valve disease, fibrosis of the myocardium in the late stages. See a normal heart, and you see a heart with diabetic cardiomyopathy. There is hypertrophy, there is fibrosis, and then a diastolic dysfunction also. See that in the ECG, you will be able to see a left ventricular pattern. And there is an STT changes also. In a stress-induced cardiomyopathy is due to a coronary vasospasm, which has been proved by coronary angiography. The cardiac enzymes, echo and angio are needed to differentiate it from acute coronary syndrome, because these are all normal in these people. And this is a typical apical balloon, Takotsubo cardiomyopathy, which shows an atrial bulging, a left ventricular apical bulging, which will have an ECG change similar to acute coronary syndrome and ST elevation, which you will have to differentiate by doing an echo here. And alcohol is one, an acute or a chronic cardiomyopathy is there, which presents with a congestive heart failure and diffuse STT changes here. See here a left ventricular which is very much dilated here. You see the ECGs, there is a left ventricular enlargement with a stress pattern also, it is there. And in coronary artery disease, which is the key here, what I would like to stress here, all of us know, the incidence is double and women die more, all of us know that. But what I would like to stress here is ECG can tell you whether there is an infarction or not. ECG can also tell you which vessel is involved, at what level the vessel is involved, and what are the other comorbid conditions it will be able to say, which will briefly I will go through it. The pathogenesis of a cardiovascular disease one is an endothelial dysfunction, which all of us know that. Increased platelet adhesiveness and changes in the plaque character, which precipitates. The localization, usually there is an anterior wall, infarction, an ST elevation. Usually it is a left anterior descending artery block. And when there is inferior, anterior and inferior can be a wraparound due to a circumflex. And left main coronary artery disease is very dangerous, very difficult even to dilate by a cardiologist, by the PCI. Have to be very careful. Usually they refer it for a CABG. Always when there is an ST segment elevation in AVR, you immediately make a diagnosis. It is a case of left main or an ostial lesion. Inferior wall lesions can be due to a right coronary or left circumflex. I'll just briefly go into it. In the left coronary artery, anterior wall myocardial infarction, you will have to answer whether it is a left main or whether it is a distal lesion. In a proximal LAD, there is an ST elevation V1 to V6, lead 1 and AVL, and an RBB can also be there. When there is a mid LAD, there is an ST elevation V1 to V6, lead 1 and AVL. Distal LAD, ST elevation in V1 to V4 only, the middle segment. The diagonal you will have lead 1, AVL, V5, we used to call it as a anterolateral wall infarction. Septal, usually you will have a bundle branch block. This is the, this is a left main lesion here. See here, AVR, there is a ST elevation. No other coronary artery disease clinical entity this occurs. When the moment you see that, you can make a diagnosis of a, left main or a coronary, left coronary ostial lesion, which are difficult to dilate. Unless you are very much experienced, the interventional cardiologists do not touch these people. When there is an ST elevation in V1 to, V6 here, V1 to V6, and AVR is normal, it is usually just distal to the, main. Here when there is ST elevation V1 to V6 and lead 1 AVL, it is a septal before the diagonals, And if there is an ST elevation V1 to V4 only, this is a, circumflex. Usually it is a lateral, And when there is a septal lesion, as I said, there will be a bundle branch block. You see here, a bundle branch block is this. Sorry, the pointer is not coming out well. And we all know inferior wall infarction is caused by a right coronary artery. But there is always a document, it could be caused by left circumflex artery. Of the left coronary artery lesion can also cause an inferior wall myocardial infarction, 2-3 AVF. And here, how to differentiate from the ECG is, when the ST elevation in lead 2 is more than in lead 3, it is circumflex. It is part of left coronary. When the ST elevation in lead 3 is more, it is a part of right coronary. These are all very few things which we need to, elders need to refresh, youth need to learn. And this is what is there in a left circumflex artery here. A right coronary artery disease, here lead 2, 3, it is more. And there can be a proximal RCA, like the proximal left coronary artery. Proximal RCA is also very dangerous. You will have to be very careful for, AV blocks, and prognosis have to be guarded. When there is a distal right coronary artery disease, it is usually very mild. You have an inferior wall changes. And there is a wave called a N wave, a notch, in the terminal part of the QRS in lead 2, 3 AVF, and it indicates a left circumflex lesion in a non-ST segment elevation. There is an entity called as a silent myocardial ischemia. All of us know in diabetic, silent myocardial ischemia is more common. Even without diabetic elderly people, silent myocardial ischemia is common. So, we say that the resting ECG is normal, can be normal. You will have to go for a stress ECG. If he is not able to do that, a perfusion imaging has to be done here. These are the various methods available here. You see here, the first one is a resting ECG. This is stress ECG. You see here, lot of more than 6 millimeters side segment depression. This is very strongly positive TMT, has to be referred for a coronary angiography. And the third point is T-wave abnormalities. We always pass on T-wave abnormalities are non-specific, but they may have a hidden importance also. There are a lot of studies available here that shows, when there is a diabetic patient with only a T-wave, you will have to suspect or screen for coronary artery disease here. Lot of evidences are there. Left ventricular hypertrophy, as I told you, without a hypertension, there can be a chamber hypertrophy, and then ECG features of a left ventricular enlargement can always be there. Very classical changes are there. Don't think that it is due to hypertension, or don't chase for an aortic valvular stenosis. Can be due to a diabetic muscular degeneration leading on to hypertrophy. Now the entity of an atherosclerotic cardiovascular disease, which is becoming very common nowadays, here a lot of things are all there. This has an abnormality of the cardiac autonomous nervous system. Thereby a lot of T-wave changes and rhythm changes are there. The prognostic parameters in diabetics through ECG. When there is a QT depression or QT interval prolongation, always we will have to be very careful with or without a dysrhythmia. In diabetic ketoacidosis, all of us know there is a potassium is there. There is a pseudo-infarct pattern will be there. You see here, there is a pseudo-infarct pattern, ST elevation. But you see there is a concavity upstairs. But in an infarct, convexity has to be there. You have tall, peaked, T-wave. It is very classical for, hyperpotassemia. And hypoglycemia can always cause an ECG abnormality, usually tachycardia as well as an ST segment depression. Sometimes if it is persistent, it can go for a torsade de pointis or a ventricular dysrhythmias or a supraventricular arrhythmias. Many a times, a prolonged hypoglycemia in the night, patient is brought to you in the morning unconsciously. Hypoglycemic encephalopathy, he has gone. See the ECG, will always be abnormal. And this is the, ECG ST segment changes in cases of diabetic hypoglycemia. There are ECG effects of many of the drugs we use, biguanide, sulfonylurea, thiazolidine. All these things have caused lot of STT changes and also cardiomegaly secondary to a cardiac failure. I'll just briefly go through one or two case scenarios and close it. Number one, totally asymptomatic person. As you see here, there is a tall, QRS here, and here is a negative. It's a left anterior hemi-block. Patient is totally, asymptomatic. Secondly, there is a sinus tachycardia with a persistent, extrasystole here. There are extrasystoles available. He is also totally asymptomatic. And here is a diabetic male with a sweating and back pain, no chest pain at all. And blood sugar is high and serum potassium is high, creatinine is borderline high. See the ECG, there is an inferior wall infarction with STT changes. You see here, tall peak T wave here, again in favor of a hyperglycemia. In addition to that, if you see carefully, there is a complete heart block. The PQRS interval is gone. There are extra P waves here that always speaks for complete heart block. It is inferior wall infarction, more common for a heart block, and there is a potassiemia is also there. And there is an elderly individual who is having an acute inferior wall infarction and anterior wall infarction, and there is a atrial flutter also. You don't see any of the, P waves here. Any diabetic patients with giddiness, don't think that it is due to a peripheral vertigo. Think that it could be due to cardiac problem. The exit for cardiac problem is always there in the, neurological problem is there in cardiac problems. And today we have got the digital ECG. Even with a wristwatch, we are able to see that. Monitor is there. And the important thing is in an atrial fibrillation, you are able to see the blood sugar. Reverse here. That, that much has come, and defibrillator can be sent through drones by the site, and this is artificial intelligence predicting. Potassium level is today normal. Says in a day or two you will have hyperkalemia, and this we are able to see that. Now I will just come to the final slides. Why ECG is valuable in diabetic people? Abnormal and asymptomatic diabetics also. The rhythm abnormalities are very common, can be brady, tachybrady, myocardial hypertrophy, coronary artery disease, as I told you, detection, the vessel location and extent of the lesion, multiple. And this autonomic neuropathy changes due to the complications of diabetes, and ECG detects cardiovascular disease in both asymptomatic and diabetic. Now, the point of actions are, did you do an ECG the day you make a diagnosis of diabetes? Don't delay that, let it be the basal one. And celebrate your birthday with an ECG. You take with the biryani and then do that, you celebrate with an ECG. Any of these symptoms, which may not be specific for cardiac, try to have an ECG. A chest pain, back pain, sweating, arm pain, giddiness, very important. Many a times we have seen, dysrhythmias as the cause of, giddiness in diabetic patient. It is not a peripheral vertigo, benign peripheral vertigo, Barani. Loss of memory, coming and going, and sudden fainting and a stroke. Always you will be focusing on, here in the cerebral vascular system, whereas lesion may be in the cardiovascular system. Thank you, sirs, for your patient listening.
Thank you very much, sir. Very interesting and very elaborate talk on
thank you so much,
ECG
sir.
in diabetes. It's very informative that apart from ischemia and infarction, so much of information can be gleaned from the ECG. So we'll take up the question at the end of the session. Okay. So we straight away go to the next topic, which is cardiovascular risk in pre-diabetes, uncovering the hidden iceberg. That will be by Dr. Sanjay Agarwal. We know that type 2 diabetes is a cardiovascular equivalent. In fact, we always say that by the time you make a diagnosis of type 2 diabetes, already cardiovascular changes have occurred. We call that a common soil hypothesis. Both occur together. But the question is, what about pre-diabetes? We know that for a very long time, that subjects with impaired glucose tolerance are in fact at more increased risk of cardiovascular disease even compared to type 2 diabetes. So to tell us about it, we have Dr. Sanjay Agarwal. Dr. Sanjay.
Good morning, everybody. It's a pleasure to be here at Chennai, and it's always a pleasure to come back again and again to Chennai. I always consider coming to Chennai as a temple because it's a seat of learning, and generations have always given India the pioneering work that comes in the field of diabetes. And I have some of the representatives of generations over here, starting with, of course, Anand over here. I'm so glad to see him after ages. and Vijay, and so many other generations who have been here, Dr. Shashaya, and I'm very happy to meet all of them over here. My task for today is to talk about cardiovascular risk and prediabetes. And it's one of the most less talked about entity, because very often we relate sort of overt diabetes with cardiovascular risk, and seldom do we really address prediabetes as one of the most important determinant of cardiovascular health. And why is this so? I mean, it's rightly so because we just see mild abnormalities which are often ignored and taken it for granted. Or more important is there are 5 different definitions for prediabetes, which comes from the WHO, International Expert Committee, as well as ADA, confusing that what actually represents prediabetes. But putting that aside, let me get to the problem that this paper that was published in the Lancet by Dr. Mohan and his group, which shows from the ICMR INDAP study, shows clearly that we have almost about 15% of patients who have prediabetes overriding the incidence of diabetes. And these are the very people who are waiting to get converted to diabetes. Now, if you look at the demographics and the heat map all across the country, you find that there isn't a single area in the country that is spared. And the urban-rural divide that was very high in the previous years has now kind of narrowed down. And we find that the lifestyle problems, as much as they are in the urban areas, also reflect in the rural areas. Important is the fact that all the cardiovascular risk markers, be it hypertension, abdominal obesity, generalized obesity, are on the rise, and we see predominantly that almost about 30 to 40% of our population tends to suffer this one way or the other. And dyslipidemia is also to the tune of about 80%. So you've got a high prevalence of prediabetes, high prevalence of all the cardiovascular risk factors, and this is a perfect substrate for future cardiovascular disease. Combine this with the fact that you've got aggressive atherosclerosis that tends to happen in diabetes, and I'm going to talk about the pathophysiologic mechanisms down the line. But what is important in terms of statistics is 80% of all diabetic mortality happens, 75% from coronary atherosclerosis and 25% from cerebral and peripheral vascular disease. And more than 75% of all hospitalizations are for diabetic complications, of which almost 50% of the patients are newly diagnosed and they have coronary heart disease. So patients may just come to you with coronary heart disease as an initial presentation, and patients may be discovered to have diabetes. Now, here's the substrate which really leads to high cardiovascular risk. And these are some of the common abnormalities that we tend to see. Patients do tend to have a high insulin resistance, high triglycerides, low HDL, and a high, small, dense LDL concentration and obesity. So these are all the determinants of cardiovascular risk that we tend to see in patients with type 2 diabetes, and particularly patients with prediabetes. Now, this is a complex diagram that is there, and I don't want to get into the depth of it all, but you can see the interplay of various risk factors, starting with hyperglycemia, and add on to the fact there's an inflammation that happens, hypertension, dyslipidemia, hypofibrinolysis, endothelial dysfunction. So there are multiple pathways which happen in presence of hyperglycemia, which increase the risk of macrovascular complications, particularly cardiovascular disease. But I just, in simplistic way, address this to say that you've got insulin resistance and hyperinsulinemia, combine that with hyperglycemia, and you tend to get a host of inflammatory reactions that tend to happen: increase in free fatty acid, increased ROS production, increased nitrous oxide, and they all tend to lead to endothelial dysfunction, ultimately through various pathways cause atherosclerosis and arterial stiffness. So is there evidence that early intervention really helps? And here's an excellent slide that I really feel that while we always keep stressing on the fact that we need to have tight glycemic control, we ignore the fact that the milieu that happens is not just related to dysglycemia, but for cardiovascular disease, there's a host of other risk factors that combine with dysglycemia to cause presence of cardiovascular disease. So macrovascular complications are determined by hyperinsulinemia, the genes, weight gain, dyslipidemia, hypertension, and then of course prediabetes or dysglycemia as it occurs early. Whereas if you look at microvascular complication, there is a clear relationship that intensive glycemic control helps in these patients. So if you want to sort of upturn evidence or upturn the incidence of macrovascular complications, our intervention should be not only to just deal with blood glucose control, but also deal with all the other cardiovascular risk markers that are evident in a patient who comes to you. And there's also evidence that has been presented by Dr. DiFranzo and his associates, which show that patients with prediabetes, and when you compare them with diabetes, the incidence of cardiovascular complications are almost similar, or they're almost on the pathway to developing a high amounts of cardiovascular disease. Now, this was also very well looked at in this paper with sort of bifurcated prediabetes into high-risk prediabetes and other prediabetes. And this was based on the entire milieu of risk factors that an individual patient carried. So the higher number of risk factors that the patient had, their risk was almost equivalent to overt type 2 diabetes. Whereas patients who had lower risk numbers were sort of more protected and were inching towards the normal glucose tolerance. So presence of atherosclerotic cardiovascular disease, heart failure, you had a clear indication that their risk profile was almost similar to overt diabetes. In chronic kidney disease, it's much lower, but in cardiovascular disease, it's almost similar. Important is the fact that we always talk about A1C, and what we do tend to miss out are trends in A1C. So if you have somebody even within the normal range and you find that there is a trend that is happening in the upward way, the cardiovascular risk tends to be proportionately high. And this was proved by the EPIC-Norflock study, which looked at, in both the genders, the presence of coronary heart disease and cardiovascular disease events and all-cause mortality. And I draw your attention to the fact that even if you look at within the normal A1C values, you do find that there patients who are destined to develop cardiovascular disease, they start the presence of risk even within the normal A1C values. And you have to be mindful of the fact that these people, when you have normal A1C, may have probably a normal glucose values, but they are sort of slowly progressing further, and if you serially monitor the HbA1cs, you'll find that there is a gradual increase, and you have to target them at that point of time if you have to reduce the cardiovascular incidence. Now, this was also looked at in another paper, and you have clearly the evidence in this forest plot that if you have diabetes of more than 7 millimoles, that's almost overt diabetes, there's an increased risk. But look at the lower section where there is no evidence of diabetes at the baseline. And here you're seeing gradual elevation of the A1Cs, and you find on the forest plot that as the A1C tends to increase, the incidence of the cardiovascular disease also tends to go up, along with the hazard ratio increasing for all-cause mortality. Now, this comes from the Nurses' Health study, and if you look at the index where there were non-diabetics during the study, and at the other extreme, you look at diabetic at the baseline, there are almost 5 times increased incidence of presence of myocardial infarction or stroke as per dysglycemic status. But look at the box that is marked out. Prior to the diagnosis of diabetes, you still have about 2.8 times higher risk of presence of cardiac disease. These are the patients who don't have overt diabetes and yet have a higher incidence of cardiovascular disease, and they're more in the pre-diabetic range. As per the QRIS scores, the ACC scores, the score 3, you find again that the QRIS scores, all these ASCVD risk scores also represent a rising trend of cardiovascular disease as the patient progresses from normoglycemia to prediabetes and undiagnosed. These are the 5 alarming facts of cardiovascular disease in India. We get premature atherosclerotic disease, so 10 years earlier onset. The comorbidities like diabetes and hypertension strike at a younger age. There's a greater prevalence of LV dysfunction at presentation, and we tend to have smaller arteries. So can we drive prevention strategies early enough? And we need to sort of identify risk factors. So while we have conventional risk factors like age, sex, family history, smoking, hypertension, and lipids, now we have an expanded risk factors that we look at where we talk about low GFRs, presence of proteinuria, metabolic syndrome, severe hypoglycemia, presence of fatty liver disease, and obstructive sleep apnea have all now got included in the armamentarium of cardiovascular risk. The evidence from various studies, and I haven't sort of taken beyond 20 because of the slide didn't permit me, but now you've got a host of agents that you can use for intervention, and this is the current guideline that we look at, that if you have ASCVD, then your first choice is of course GLP-1 analog and followed by SGLT2 inhibitors. And if your goals for blood glucose is not met, then you can move on to the other agents. Similarly, for heart failure, your first goal is of course to start the patient on SGLT2 inhibitors followed by other agents. But what is important is of course the weight management, the lipid management that you tend to have, and the blood pressure goals that you need to meet. And these have to be simultaneously started along with blood glucose control. Here's the evidence that says that does intensive glucose control help? And you can see from all these 4 studies that while there was early evidence of reduction in microvascular complications, there was not really much benefit in cardiovascular disease incidences, either immediate early onset or late onset. There was not much benefit that you got by only intensive glucose control. So it boils down to the fact that if you look at all the multiple risk factors, and this comes from this study, which said that if you have no diabetes, and then you compare that with multiple risks that you get, the higher number of risk factors you get, it compounds the risk for cardiovascular disease. So here you've got diabetes with 1 or 2 risk factors, 3 to 4 risk factors, 5 to 6 risk factors, and 7 to 9. And you find that the exponential increase in the risk that tends to happen with more number of risk factors. So now today we believe that we need to do multiple risk interventions, and you've got InterHeart study, the STENO2 study, and so many studies which had looked at the benefit of intensive control, which looked at multiple risk interventions that you tend to get. And here are the different risk 9 modifiable factors that account for almost 90% of the first MI risk worldwide. And you need to ensure that you do a multiple risk intervention rather than look at only the glycemic control. So I'll my talk in the last 1 minute that I have, that what do we understand? Patients with diabetes are at increased risk for coronary artery disease. No question, there is good data about it. Are all patients with diabetes to be treated as coronary heart disease equivalent? That's questionable, no convincing data. Can we identify populations of patients which need more intensive care for aggressive intervention? Sure. Look at the age, duration of diabetes, total risk burden, coronary artery calcium scores, and you'll have a perfect substrate. There's always a question of, do we need to screen asymptomatic patients for coronary artery disease? And that's open for debate because the evidence says no, and there are a lot of protagonists who say we should do it. But what is universally accepted is the fact that we need to put prevention strategies in place. While the Whitehall study tells us that the risk for diabetes starts much earlier in life, and if you look at the entire timelines or life course of an individual, you find that almost 5 years before the onset of diabetes, you find that the patient has already started showing evidence of those who are going to progress to diabetes. And here are some of the early predictors of transition from normal glucose regulation to prediabetes. What stands out is, of course, you look at the demographic and adiposity markers, look at the glucoregulatory measures, look at the other sort of lipid markers, the the lipid and the liver markers, and you look at so many other inflammatory markers that points out to the fact that these are the patients who develop prediabetes. I just want to give my last slide, and this was by the American Heart Association, which says they now talk about life's essential 8. And we need to sort of enforce this life essential 8 in all our patients with diet, exercise, looking at the glucose control, weight management, lipids, the blood pressure goals, cessation of smoking, and good sleep. And this is what is important that we need to advocate in all our patients. Thank you very much for your patient listening.
Thank you, Dr. Sanjay, for excellent presentation, a very comprehensive coverage of the topic. As I've been asked, that question as a session will be at the end with all three speakers
Please,
together.
thank you very much.
So stay with us, yeah. So there is some change in the schedule. Next talk is, that was supposed to be the first talk for today. That is current RSSDI guidelines in diabetes management. And Dr. M. Shanmugam will be speaking on this topic. Over to Dr. Shanmugam.
Can I have my slides? Respected chairperson, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on current RSSDA guidelines for the management of patients with type 2 diabetes. So my presentation will be on current RSSDA guidelines in diabetes management with a particular focus on evidence-based findings. I thank the chairperson. I also thank the organizing committee members for their kind invitations. My disclosures, what I'm going to do for another 15 minutes. The contents of my talk mainly includes introduction, historical background, RSSDA clinical practice recommendations 2022, individualizing therapies and precision diabetology, the so-called ABCDEFGH approach, case-based discussion using RSSDA therapeutic wheel, and of course conclusions. So type 2 diabetes is a progressive metabolic disorder characterized by abnormal insulin secretion and utilization. So Indian patients have distinctive clinical and biochemical characteristics, the so-called Asian Indian phenotype. They have greater propensity to develop cardiovascular complications such as atherosclerotic cardiovascular disease, heart failure, and CKD. At the same BMI, more Asians develop MET syndrome. Numerous international and national guidelines are in place for the management of patients with type 2 diabetes. Adopting country-specific guidelines improves treatment outcomes in patients with diabetes. So historical background. So RSSDA CPR, clinical practice recommendations 2015. Asian Indians have increased metabolic risk compared to Western counterparts due to hyperleptinemia, leptin resistance, hyperinsulinemia, insulin resistance, and lower acute insulin response, the so-called thin fat Indian or sarcopenic obesity. So RSSD published the clinical practice recommendation, which was adapted from 2014 global guidelines for type 2 diabetes by International Diabetes Federation. So 2015 specifically designed considering the diverse socioeconomic and cultural background of Indians. So this was well accepted by the healthcare professionals across India and helped in decision making. However, diabetes research is continuously evolving. So CPR 2017, several publications are being added to the literature, which can significantly impact holistic diabetes care. So addition of new drugs, that is transforming the treatment of patients with type 2 diabetes. So 2020's clinical practice guidelines. All of the sections have been updated with recent evidences. 3 new sections, hypoglycemia, diabetes, and CV risk and technologies have been incorporated. The objective is to provide evidence-based recommendations for the treatment of patients with type 2 diabetes. So it is expected that these recommendations will help define practically implementable best practices not only for the management of type 2 diabetes, but also timely prevention of acute and chronic complications of diabetes by primary care physicians. And drug choice should be based on patient preferences, various comorbidities and complications, drug characteristics with the goal of reducing blood glucose levels while minimizing side effects. So the patient-centric approach may be referred to as the ABCDEFGH approach for diabetes management, that is RSSDA CPR 2020. So South Asian phenotype, endorsed by Professor Dr. B. Mogan et al., the so-called Asian phenotype, engage at onset, hyperinsulinemia, rapid decline in beta cell function, lower BMI, lower muscle mass, reduced levels of adiponectin, increased circulating inflammatory markers, and so on. So the lessons learned, causes, ethnic, genetic, and multiple factors, lifestyle factors, and improving the nutrition, especially reducing the carbohydrate intake, increasing the protein, restricting the fat intake, and very important thing is minimizing exposure to pollution. So RSSD clinical practice recommendation 2022, the factors relevant to the Indian context, we know the prevalence, the complications with reference to sedentary lifestyle, and the list and the cost of the diagnosis, treatment, monitoring, as well as prevention, as well as the limited resources. So medical nutrition therapy remains a major cornerstone, of course, with reference to carbohydrate intake, protein intake, fat intake, salt intake, as well as encourage physical activity. So recommendations for medical nutrition therapy with reference to carbohydrate, protein, next is fat. So diet rich in fruits, leafy vegetables, nuts, fiber, whole grains, unsaturated fat, pulses, legumes, unprocessed vegetables, and low-fat dairy, salt consumption less than 5 grams a day, and artificial sweeteners. So next is physical activity. 150 minutes of physical activity, that is not sufficient. More than that we need. And very important thing is more than 30 minutes of moderate intensity aerobic activity, 15 to 30 minutes of work-related activity, and 15 minutes of muscle strengthening exercise. And for Asian Indians, predisposed to develop type 2 diabetes or CV risk, and additional 60 minutes of physical activity each day is recommended, although there is limited data to support this recommendation. Please bear in mind, 150 minutes per week is not enough for our Asian Indians. So individualizing therapies and precision diabetology, ABCD, GH approach, RSSD clinical practice recommendations. So RSSD therapeutic wheel in the following case studies. So hierarchy of therapy is depicted in clockwise. So if you look into the central point, lifestyle modification, followed by metformin, and use any drugs that is shown in green color, of course with restriction with reference to orange and yellow color. So most drugs have been considered from orange zone in order of hierarchy, and numbering against each drug is treatment options depicts orders of preference based on hierarchy from RSSDA Endocrine Society of India wheel. So individualized therapy, choice of any OADs should consider the patient's general health status, associated medical disorders, and patient-centric approach, and that is the approach for diabetes management. For any type 2 diabetic patients, the first line of therapy is metformin, unless not tolerated by the patients or contraindicated. So when you see a patient in your clinic, prescribe lifestyle intervention, metformin to most of the patients, identify 2 or 3 most important concerns or factors you feel should influence your choice of anti-diabetic drugs with reference to A, B, C, D, E, F, G, H. Identify the best choices available from the outer rings. Further, fine-tune your choice if more concerns exist. Make a rational final choice with an individualized approach. Identify complications and management strategies. So individualizing ABCDF approach, A stands for age. We have the DPP-4 inhibitors which may be more suitable because it is associated with the low risk of hypoglycemia, weight gain, and dosage can be adjusted as per EGFR. Next alternative is alpha glucosidase inhibitor, good choice for elderly patients. They do not cause hypoglycemia and could be a good choice for elderly patients, and especially in terms of glycemic reduction in Asians because of high carbohydrate diet. The use of glutazones is restricted because of weight gain, fluid retention, peripheral edema, as well as congestive heart failure, osteoporosis in postmenopausal women. Next is neosulfonylureas. That is extended formulations, low-dose glycoside or low-dose glimepiride. They are associated with the low risk of hypoglycemia. These classes provide good glycemic control in patients with the type 2 and can reduce the CV risk. Of course, cost, the discomfort of injection, weight loss associated with GLP receptor analog, hypovolemia, postural hypertension, and euglycemic diabetic ketoacidosis, and weight loss with SGLT2 inhibitors may limit their usage in some frail elderly type 2 diabetic patients. Next is basal insulin analogs. Become the Glorgine, Detamir, and Degludec. They are effective, safe, with less risk of hypoglycemia. Addition of modern insulin analogs to OAD in older patients was effective with regards to low risk of hypoglycemia. So individualization, that is highly desirable based on the risk of comorbidities, functionality, cost, and personal preferences. So individualized treatment summary with reference to modern sulfonylureas, DPP-4 inhibitors, alpha-glucosidase inhibitors, and SGLT2 inhibitors. Next is B, that represents the body mass index. Overweight or obese patients. One should first consider anti-diabetic medications which cause either weight loss or weight neutrality. We have GLP-1 receptor analog and SGLT2 inhibitors, which are associated with weight loss. DPP-4 inhibitors and alpha glucosidase inhibitors, they appear to be weight neutral. GLP-1 receptor and SGLT2 seem to be the best add-on therapy for those having high BMI. Next is careful consideration should be given to possible, especially those patients if you want to prescribe SGLT2 inhibitors or GLP-1 receptor analogs. And DPP-4 inhibitors are shown to be more effective in Asian patients in general, especially more in Indians. Sulfonylureas like glycoside and glimepiride do not result in significant weight gain. And lean patients with the type 2 and low BMI, they are a distinct group of patients which are common in India. So individualized treatment for type 2 diabetes, BMI, we have the drug class and the effect on weight. Next is CKD. C stands for CKD. In patients with renal impairment, preference of therapy would be the SGLT2 inhibitors or DPP-4 inhibitors. And some DPP-4 needs adjustment as per EGFR. And repagliflozin is another agent which may be used across all stages of renal insufficiency. And sulfonylureas like glycoside, as well as glimepiride, with dosage modification can be prescribed in patients with renal impairment. Of course, we have the GLP-1 receptor analogs. Next is alpha glucosidase inhibitors can be used in patients with mild to moderate renal impairment, and use of pioglitazone is restricted, and insulin can be used at any stage of renal insufficiency. So individualized treatment for patients with the type 2 with the CKD, it is given in this particular table. Again, drugs, EGFR and consents. Next is D stands for duration of diabetes. So patients with long-standing diabetes, they are difficult to treat because these patients often lack sufficient beta cell function to respond to secretagogues. They may have other comorbidities, including renal impairment. So insulins are often used in patients with long-standing diabetes, and we have the incretin-based therapies, particularly GLP-1 receptor analogs. They reduce the A1C significantly and have low rates of hypoglycemia. And SGLT2 inhibitors may also be useful as an add-on. And alpha glucosidase inhibitors can also be effective sometime owing to their beta cell independent actions. Next is patient with established cardiovascular disease, A, B, C, D, E. In patient with established cardiovascular disease, we know our own guidelines. Next is international guidelines. They recommend to prescribe SGLT2 inhibitors or GLP-1 receptor analogs. Of course, data with reference to glimepiride from the Carolina trial clearly shown the benefit, clearly shown the safety of sulfonylurea while managing patients with established cardiovascular disease. And alpha glucosidase inhibitors have demonstrated severe risk reduction by reducing inflammation as well as postprandial hyperglycemia. Considering that many Indian patients have to pay for the treatment and OPD visits and continued lifelong treatment, cost of therapy plays a crucial role in patients with the type 2 diabetes from the Indian context. So sulfonylureas can be a good addition to metformin, considering the cost in the light of recent Carolina trial demonstrating cardiovascular neutrality of glimepiride compared to linagliptin. Next is financial concern, especially with reference to insulin, and pioglitazone or inexpensive DPP-4 inhibitors or SGLT2 inhibitors can also be considered when combinations of sulfonylurea and metformin cannot achieve the desired goal. So individualizing therapies based on the glycemic status, we have the order of priority in terms of reduction of A1C from insulin, GLP-1 receptor analogs, SGLT2 inhibitors, pioglitazone and DPP-4. Next is hypoglycemia concern. So hypoglycemia is an important limiting factor. Insulin, sulfonylureas and glinates have increased risk of moderate to severe hypoglycemia. Initiating DPP-4 inhibitor on the background of secretagogue, we need to monitor. And in prescribing SGLT2 inhibitors on the top of secretagogues, we should be a little careful. So in patients with existing hypoglycemia, or those at high risk of hypoglycemia, GLP-1 receptor analogs or SGLT2 inhibitors or DPP-4 inhibitors or alpha glucosidase inhibitors or pioglitazone should be considered. So individuals in whom hypo further poses risk include patients with established cardiovascular disease, elderly patients, patients suffering from CKD, and patients who stay alone, patients with shortened life expectancy, patients having documented hypo-awareness and autonomic neuropathy. So individualized treatment based on the hypoglycemia concern. We have the insulin, DPP-4, alpha glucose inhibitors and so on. So case-based discussion using RSSDA therapeutic wheel. So I have explained the therapeutic wheel, and here is a patient, 48-year-old male businessman, A1C increasing to 8.4, additional history, further attempts a lifestyle change, unsuccessful, and post-medical history, hypertension or ramipril. If you look into the parameters, fasting, postprandial A1C, triglycerides are elevated. So businessman, type 2 diabetes, 3 years, declines injectables, obeys, BMI 32.5, ECG normal, which OAD next. So based on RSSD therapeutic bill, which sections are relevant? Age, BMI, duration, oral therapy, which are common drugs relevant to these? So based on the ABCD approach, you can implement in your day-to-day practice. So treatment options, we get the options, and next is with reference to SGLT2 inhibitors, DPP4 inhibitors, as well as the good patient education. So RSSD therapeutic wheel, we have the drugs also incorporated in the therapeutic wheel. So conclusion, so the health impact of type 2 diabetes is well known. Its management has substantial effect on individual and societal health, psychological well-being, quality of life, and economic repercussions. Clinical practice recommendation in diabetes management are tools for healthcare providers. There is no one-size-fits-all treatment for patients with the type 2, and diabetes management should be individualized. And AD also highlights the importance of patient-centric care, which is respectful of and responsive to individual patient preferences. And individualized therapy for type 2 could serve as a real-world approach, providing care that is responsive to individuals' specific unique needs, preferences, and values, and also helping to combat adverse long-term outcomes. So before I conclude my talk, I extend my warm welcome to all the eminent members gathered here to register for this forthcoming RSSD National Conference scheduled for November 14th to 17th, New Delhi, and yet another RSSD research retreat that is set for March 1st and 2nd, 2025 in Madurai, and make this a memorable and a successful event. Thank you very much for your kind listening.
Thank you, Dr. Shanmugavelu. As usual, a rapid-fire presentation, which is expected from you with a lot of clarity and message. Thank you so much. So in this session, we have had 3 sessions. First was Dr. Arul Raj, an excellent overview of the ECG. I think you went beyond probably what the audience could have expected, including the localization of the ischemic lesion just from the ECG. At least you can suspect. I think it calls for so much of academic reasoning when you just have an ECG in front of you, besides the other aspects. Then Sanjay did a good job with the available information, how the clinicians should look at the prevention of the or anticipate cardiovascular disease with respect to the co-aggregation of the risk factors, even in the pre-diabetic stage. And the evidences that you presented were very compelling, and the intervention that you suggested towards the end. And of course, lastly, we had the beautiful, versatile presentation from Velu. Now, already we are about half an hour behind schedule. So I was told that if there are any pressing questions or comments, maybe we'll have 2 questions before we take on the oration and the subsequent inauguration.
There will not be any session without Dr. Professor Parandaman's question.
Yeah, Parandaman and Professor Lakshmi Narayanan, then we'll wind up.
Thank you.
Thank you for the interesting interrogation. Whether it is a transesophageal echo or ECG?
ECG.
ECG.
Yeah.
It is rarely done, sir. Transesophageal echo is a real, need.
Yeah. The true
When there is,
true posterior wall infarction can be
Yeah.
diagnosed only by
only by that, but nowadays, when you do the V3R and V4R leads, or even posterior leads, we are able to do it, sir. We need not trouble an infarct fellow with a transesophageal ECG to make a diagnosis. You do an echo, we are able to do that, sir. When there is when you suspect a mass or a embolization from the cardiac system, cardiovascular system, he has a cerebrovascular stroke, a TE is really useful, because the chamber could have been emptied by throwing away the clot. You will be able to see posteriorly when you go there a left atrial appendage or left atrium. You will be able to see either a heart clot or a spontaneous echo contrast, which presents a soft clot, sir. And transesophageal ECG is nowadays rarely done, sir. For academic things, we should. Thank you, sir. Thank you.
Sorry, sir. This is for Professor Sanjay Agarwal, sir.
Okay, okay.
Regarding the IGT, the increase of cardiovascular complication in IGT, in addition to the insulin resistance, higher insulin levels, is it due to non-insulin dependent glucose uptake by the endothelium matters than the other factors? Because this endothelium doesn't require insulin for glucose uptake. Even slight increase in glucose might aggravate the glycemic burden and cause the
So
endothelium
I think
damage.
it's just not only the glucose. There's a lot of inflammatory pathways that also contribute to the endothelial dysfunction. So while you've got, of course, insulin resistance is one of the mechanisms through which it happens. You've got a host of other sort of inflammatory pathways which sort of cause an aggressive atherosclerosis and plaque sort of formations, which is actually more important because that's where probably the whole role of aggressive statin therapy is getting more and more, sort of traction to.
Before we wind up, Dr. Sanjay, can I ask you one small clarification? Is it true that there is a discordance between impaired fasting glucose and impaired glucose tolerance with reference to cardiovascular disease because of the different underlying pathological mechanisms?
Yeah, I mean, basically the thing is impaired fasting. Where does your fasting glucose come from? It's more from the hepatic glucose output that you tend to get. And it's more of a resistance effect that you tend to get. And more often than not, an impaired glucose tolerance is from secretory defect that you tend to get. So there is, I mean, it's more generalizable that we are talking about. It's not hard and fast, it works that way. But it's always a combination of deficiency and resistance that you tend to have. It's just that way.
Thank you. Thank you. I think we'll wind up with that. I again thank the organizers for giving us this opportunity. Thank you.